We begin our lecture today on diabetes. Our objectives are to define diabetes mellitus, compare and contrast type 1 diabetes mellitus with type 2 diabetes mellitus, explain the main goal of diabetes treatment and how it is achieved, discuss the composition and process of the diabetes management team, describe current nutritional therapy guidelines, and identify groups for which special care and individualized goals are needed. Diabetes mellitus is a group of conditions characterized by a relative or complete lack of insulin secreted by beta cells or by the defects of cell insulin receptors. This alters the metabolism of carbohydrates, proteins, and lipids. It also alters blood glucose levels. A person is considered diabetic if the fasting blood glucose is 126 in 2 consecutive testings that must be fasting 8 hours before. Diabetes mellitus can be macrovascular or microvascular. Macrovascular complications include coronary artery disease, peripheral vascular disease, cerebral vascular disease, while microvascular results in nephropathy and retinopathy. Impaired healing results in gangrene and amputations due to circulatory defects of diabetes mellitus. Long-term complications correlate to the number of incidents of hyperglycemia in a lifetime. There are 2 classifications of diabetes mellitus. Type 1 is 5 to 10% of patients, and type 2 is more than 90% of patients. GDM, known as gestational diabetes mellitus, is what results in pregnancy for some people. The hemoglobin A1C is a test that is used to determine compliance with diabetic controls. The goal for the patient with diabetes is a hemoglobin A1C less than 7.0. The clinical implications are dental diseases, periodontal diseases, skin conditions, fungal infections, acanthosis nigricans, buliosis diabeticorum, blisters, congenital malformations of the fetus. Good blood glucose control is essential to prevent that. Postural hypotension, persistent tachycardia, neurogenic bladder, which can result in incontinence and impotence. Type 1 diabetes must have insulin therapy to survive. No endogenous insulins. In other words, they do not make their own insulin. Usually it's sudden onset, faster in infants and children. Usually the first diagnosis is under age 20. The first manifestation may be diabetic ketoacidosis. Some signs and symptoms are unintentional weight loss, irritability and other mood changes, fatigue and weakness, blurred vision, as well as polyphagia, polydipsia, that can be extreme, and polyuria, resulting in bedwetting in children. This is a graphic that kind of shows how it happens in diabetic 1, how the glucose is overwhelming in the blood cells because there are no insulin to carry it around to the cells. Insulin in type 1 diabetic patients require exogenous insulin, which means they need to have insulin given to them or to give it to themselves. Type 2 or some patients require insulin. Patterns of insulin administration vary among individuals. The goal is to maintain glucose levels as close to physiological normal as possible, accomplished by varying timing and dosages of insulin. Conventional and standard insulin therapies, flexible intensive insulin therapy, continuous subcutaneous insulin infusion, better known as an insulin pump. Nurses have to teach how to store their insulin, what the peaks of certain insulins are, and the duration of it. The goal is to integrate insulin regime with a patient's lifestyle. Type 2 diabetes is a little different. Some type 2 diabetes will need insulin for control, some only need oral control. This is kind of a graphic picture looking at diabetes type 2, where there's plenty of insulin to carry the glucose around, but it just can't get it into the cells because of receptor problems. 90 to 95% of patients have diabetes type 2. Symptoms are gradual onset of polyuria and polydipsia, polyphagia, easily fatigued, and have frequent infections, especially of the urinary tract. May have conditions for many years before complications lead to diagnosis. This is caused by insulin resistance or failure of cells to respond to insulin or defects in insulin secretion. Pancreas failure and beta cell exhaustion are common in the obese. goal is to mimic the normal glucose metabolism. Risk factors. Significant risk factors are family history and obesity, particularly childhood obesity. Obesity produces an insulin-resistant state. Upper body obesity is defined by waist-to-hip ratios greater than 0.8 in women and 0.9 to 1.0 in men. Greater risk factor than degree of obesity. Metabolic syndrome contains 3 of the 5 risk factors present: waist circumference, increased triglycerides over 150, low HDL less than 40 in women and men, or in men, and less than 50 in women. That's less than 40 in men. Systolic blood pressure greater than 130 or diastolic greater than 85, and a fasting blood glucose of greater than 100. Pancreatic transplant is one of the treatment alternatives, and usually comes with a renal transplant patient. Long-term effects are still present even with transplant. Isolate cell transplantation, bariatric surgery for BMI greater than 35 with comorbidities, and dialysis, whether it's peritoneal or hemodialysis. So your oral hypoglycemic agents: metformin, your sulfonylureas, glyburide, glinase, they stimulate secretion of insulin. Thiazolone, Actos, and Avandia improve insulin sensitivity, treats insulin resistance. However, it's highly contraindicated with congestive heart failure. With our metformins, here up at the top here, we want to make sure that we understand that we have to protect their kidneys if they're going to be in surgery. So we stop them taking the metformin for 48 hours prior to any contrast dyes. They could risk a high rate of acute kidney injury. DP4 inhibitor Januvia. It lowers glucose by assisting body to make more insulin, keeps liver from storing glucose as glycogen. Megalantinide, Prandin, helps body make more insulin after a person eats for a short period of time. Combination injectables are available. Exercise. Exercise lowers the blood glucose levels, assists in maintaining normal lipid levels, and increases circulation. Exercise guidelines for diabetic fitness: frequency 3 to 4 times a week, intensity 60-80% of maximum heart rate, and time aerobic activity 20 to 30 minutes with 5 to 10 minutes warm up. Type 1 diabetics, glucose control can be compromised if food and insulin are not adjusted. Type 2 diabetes patients may be at risk for hypoglycemia while taking oral agents and exercising. General guidelines for exercise in type 1 diabetic mellitus: avoid exercise if glucose levels are greater than 250 with ketosis or greater than 300 regardless of ketones. No exercise at the peak of insulin. Before exercising, ingest additional carbohydrates, especially if glucose levels less than 100. Monitor your BG levels before and after exercise and learn how to adjust food and insulin. Consume an added carbohydrate as needed to avoid hypoglycemia. Keep carbohydrate-based foods available during and after exercise. Blood glucose monitoring. Glycosylated hemoglobin A1C reflects the blood glucose for control for 100 to 120 days. Hemoglobin combined to glucose, glycohemoglobin, can be drawn at any time. Goals are less than 7%. Preprandial is 90 to 130. Postprandial is less than 180. More exposure of red blood cells to glucose equals increased A1C. Self-monitoring, useful to evaluate effectiveness of meal plans in meeting goals of nutritional therapy. Hypoglycemia causes too much insulin, skipping meals, too much exercise without food replacement. Few of the signs and symptoms up here in the right-hand corner. Remember, if they're cold and clammy, give them candy. It's a good old adage. Rule of 15 to treat hypoglycemia. Follow these rules. BG is less than 70. Ingest 15 grams of simple carbs, juice or soft drink. Recheck in 15 if less than 70. More simple carbs, if not improved in 2 to 3 doses, contact healthcare provider. So here's DKA, diabetic ketoacidosis. The causes are insufficient or interrupted insulin therapy, or too much food infection, other stressors, trauma, surgery, emotions. MI. Consequences: hyperglycemia, osmotic diuresis, dehydration, lactoacidosis, lower pH stimulates respiration center, Kussmaul's respiration, and fruity or acetone breath. Hyperglycemic hyperosmolar syndrome, insulin deficiency resulting in severe hyperglycemia attributed to stress, trauma, or infection. Insulin is present to prevent ketosis and acidosis, but not enough to prevent hyperglycemia. Consequences: hyperosmolar serum, osmotic diuresis, electrolyte depletion, death rate of 10 to 25%. Nutritional therapy: attain and maintain optimal metabolic outcomes, blood glucose, lipid, lipoprotein profiles, blood pressure. Prevent and treat chronic complications. Improve health through healthy food choices and physical activity. The patient can eat regular food. They just need to be aware of and able to count their carbs. Most non-nutritive sweeteners are approved by FDA. So what's the role of the nurse? Considerations are age and setting, assessing the knowledge and understanding and adherence of the patient and their family. Monitor glucose to check compliance. Non-compliance is a lack of knowledge versus a lack of motivation. Care plan, real life management, and a trusting relationship. Special considerations: the blood glucose levels increase with illness, while the appetite decreases and the liver increases glucogenesis. How do we manage this? We monitor blood glucose levels at least 4 times a day. We test urine for ketones. We continue to take insulin to prevent ketoacidosis. May need to adjust medication doses. May need insulin. Likely be DC'd when condition improves. Ensure patient receiving adequate carbs. May require liquids, semi-liquid, or soft foods. Drink liquids every hour. May need small amounts of salty food after vomiting and diarrhea. If unable to eat, should consume small meals in liquid or soft forms of carbohydrates. Check blood sugar frequently, 4 to 8 times a day. Any questions? Please text or email with any questions you may have. Thank you.